Hi guys, welcome to another lecture in the series Medicinal Chemistry 2, and today we're going to be speaking about anti-hyperlipidemic drugs. So they're also called hypolipidemic agents, and they're a diverse group of pharmaceuticals that are used in the treatment of hyperlipidemias. They're also called lipid-lowering drugs. So throughout this lecture, you might see LLDs or agents. So lipids in human plasma are transported in complexes with lipoproteins. So what are lipoproteins? Well, it's a biochemical assembly that contains both, as the name suggests, proteins and lipids. And of course, we know lipids are fats, right? So this lipoprotein has fats as well as proteins. So the lipids or their derivatives may be covalently or non-covalently bound to the proteins, right? And we know the implications of this. So many enzymes, transporters, structural proteins, antigens, adhesins, and toxins are actually lipoproteins. So hyperlipidemia is as a result of an elevation of plasma lipoprotein. So increased levels of plasma triglycerides is termed hyperlipemia or hyperlipemia. Increased levels of plasma cholesterol is termed hypercholesterolemia. Hyperlipidemia or hyperlipoproteinemia can result in acute pancreatitis or arteriosclerosis. And we have an image here to your right showing the normal artery and the narrowed artery that clearly has some plaque on the inside. So acute pancreatitis results in patients with hyperlipemia. In such patients, control of triglycerides can prevent recurrent attacks. Alright, so let's talk a little about lipoprotein transport in the blood. So lipids and cholesterol are transported through the bloodstream as macromolecular complexes of lipid and protein known as lipoproteins, right? So both lipids and cholesterol are transported through the blood in these complexes. These consist of a central core of hydrophobic lipids or triglycerides, and we'll see how that looks in a little bit, or cholesterol esters. So they're encased in a more hydrophilic coat of polar substances known as phospholipids, free cholesterol, and associated apolipoproteins. Now, apolipoproteins are proteins that bind lipids to form lipoproteins, right? So this is basically what we're talking about here. We have the outer, phospholipid, as we said. We have the inner central core of triglycerides. So that's the green part here. The inner central core of triglycerides. And of course, we have our free cholesterol here being the yellow dots, and as we can see, there's an increase here as we go across. And of course, we have our proteins associated with this complex. All right, so the lipoproteins differ in the relative proportion of the core lipids, the type of apoprotein, the size, and density. So there are four main classes of lipoprotein based on the density property. So we have our chylomicrons seen here, and we have our VLDL. So throughout this lecture, I'm sure you'll mainly see VLDL or LDL or HDL. So to define them, VLDL means very low density lipoproteins, LDL means low density lipoproteins, and HDL means high density lipoproteins. So as we can see, they differ in terms of the relative proportions of the different components, right? So clearly for HDL, which are high density lipoproteins, we have here a lot of cholesterol and less triglycerides, as opposed to our chylomicron, which has, a lot of triglycerides and very small amounts of cholesterol, relatively speaking. So this is basically how they are, and we're also seeing an arrow which suggests that there is some conversion going on. So in the liver, you have conversion of your chylomicron to your VLDL, and then your adipose tissue converts your VLDL to your LDL, and other tissues converts your LDL to your HDL. So I mean, these are the four main classes, and they are converted to each other based on this diagram that we see here. All right, so our lipoproteins, still talking about our lipoproteins, these are the vehicles that transport lipid in the bloodstream between sites of absorption, synthesis in the liver, storage in the adipose tissue, and utilization in other tissues. So we're going to speak briefly about these lipoproteins. So your chylomicrons, which is the first one that we spoke about here, they transport triglycerides and cholesterol from the GI tract to the tissues. All right, so as we see here, and I'll keep going back to this image, here we can see that the majority of the chylomicrons are triglyceride, and to a lesser extent cholesterol. So they transport triglycerides and cholesterol from the GI tract to the tissues, where they are split by lipoprotein lipase, releasing free fatty acids. These are taken up in the muscle and adipose tissue, right? So here is an example of a triglyceride, right? So basically what happens in the presence of lipoprotein lipase, you have conversion of your triglycerides to your free fatty acids, and you will see FFA. Sometimes that means free fatty acid. So essentially, clearly some type of hydrolysis happened. We have a ester bond here that can hydrolyze to release or fatty acid. So this side of the molecule, the carboxylic acid side, well, if it hydrolyzes, it will be here. So we have this side, which this will be a carboxylic acid, and so we have, once this bond breaks or hydrolyzes, it's a ester bond, so we get alcohol on this side and the acid on this side, and so these are our fatty acids, sorry. So the triglycerides are converted to free fatty acid via lipoprotein lipase. So let's read through that again. So our chylomicrons, they transport triglycerides and cholesterol from the GI tract to the tissues, where they are split by lipoprotein lipase, releasing free fatty acids. These are taken up in the muscle and adipose tissue, right? So here we can see tissue uptake occurring here. All right, so our chylomicron remnants are taken up in the liver where cholesterol is stored, oxidized to bile acids, or released into VLDL, right? So that leads us to our second lipoprotein, which is VLDL. So they transport cholesterol and newly synthesized triglycerides to the tissues where triglycerides are removed as before. And onto your LDL and HDL, or LDL, with a large component of cholesterol, as we can see, a large yellow portion, some of which is taken up by the tissues and some by the liver by endocytosis by specific LDL receptors. Now your HDL, they absorb cholesterol derived from cell breakdown in tissues, including arteries, and transfer it to VLDL and LDL. All right, so in terms of your lipoproteins metabolism, VLDL transports endogenous products. So we can see it on this side. We have our endogenous pathway and we have our exogenous pathway. So your exogenous pathway clearly from your dietary fat, and then your endogenous clearly would be from within you. So VLDL transports endogenous products, whereas our chylomicrons transport exogenous or dietary products. And just to mention here that ideal, because we haven't mentioned that before, there is actually an intermediate density lipoprotein. So we have our high and low density. There's also an intermediate lipoprotein. Intermediate density lipoprotein. All right, so let's look a little bit at our exogenous pathways. So we have our dietary fat, and they combine with our bile acids and cholesterol, and through our intestine we get to our chylomicrons, and then, as we mentioned already, lipoprotein lipase converts our triglycerides to our free fatty acids, and that's taken up by body cells and assembled into triglycerides. So this happens in your blood capillary. So the remnants, the chylomicron remnants, after the lipoprotein lipase does its activity, there are remnants, and there's a remnant receptor in the liver, and it intakes dietary cholesterol. And essentially, as we can see, there's a connection between our exogenous pathway and our endogenous pathway, and they are similar in terms of how they operate. So we also have our lipoprotein lipase here that converts our VLDL to in our blood capillaries, and it also liberates our free fatty acids and IDL, which we mentioned already, or intermediate density lipoprotein, and then that gets converted to your LDL and eventually to your HDL, as we saw in this picture here. So HDL exert several anti-atherogenic effects. Low levels of HDL are an independent risk factor for coronary disease. The higher the plasma concentration of LDL cholesterol and the lower the concentration of HDL cholesterol, the higher the risk of ischemic heart disease. So essentially what you want is more HDL And that is considered to be the good one, so to speak, in terms of good versus bad. And the LDL and the VLDL are considered as bad. So these are some top foods to increase good or HDL cholesterol. So here, we're not going to go through all of them. I'm sure you have an idea already. What are the types of food? You have your eggplant, cabbage, celery, okra, oatmeal, your fishes, good source of HDL, your grapes, citrus fruits, strawberry, etc., etc. Your nuts and garlic, avocado, for example. So essentially, there is a way. I know this course is about medicinal drugs. However, if you can change your diet to have a better HDL cholesterol balance, then why not? All right, so total fat calories should be 20 to 25%, with saturated fats less than 8% of total calories, and cholesterol less than 200 milligrams per day. So this regimen produces a 10 to 20% reduction in serum cholesterol. An increase in complex carbohydrates and fiber are recommended, and monounsaturated fats should predominate within the fat allowance. Weight reduction and calorie restriction are especially important in patients with elevated VLDL. Patients with hypertriglyceridemia should avoid alcohol. All right, so now we're going to be talking a bit about lipid lowering drugs, right? So if you do have these high plasma LDL, there is a way to lower it via the drug route. So several drugs are used to decrease plasma LDL cholesterol. Drug therapy to lower plasma lipids is only one approach to treatment, and it's used in addition to dietary management and correction of other modifiable cardiovascular risk factors, right? So it's not about popping a pill, taking a drug, it's also about monitoring your diet. Alright, so the main classes of drug used clinically are bile acid binding resins or bile acid sequestrants, and you have your fibrates, you have your statins, which are your HMG-CoA reductase inhibitors, and you have niacin, and of course there are others, but these are your four main classes of drugs used clinically. All right, so let's talk a little about niacin, which is the first class. It's a water soluble vitamin, and lipolysis is inhibited. Free fatty acids is decreased. Triglycerides is decreased. So these are the things that happen when you take niacin. VLDL, LDL is reduced. Cholesterol is reduced, and HDL is increased. So niacin is also nicotinic acid, and this is the structure of niacin is 3-pyridine carboxylic acid. It's a very simple structure. So nicotinic acid or niacin reduces the plasma levels of both VLDLs and LDLs by inhibiting hepatic VLDL secretion, as well as suppressing the flux of FFA, which is free fatty acid, release from adipose tissue by inhibiting lipolysis. So here we have niacin. and we see a connection here between adipose tissue and the liver, and niacin causes decreased FFA release, and we also see decreased VLDL and therefore decreased LDL, and of course increase HDL, right, and decrease triglyceride synthesis. So that is basically the mechanism of action for niacin or nicotinic acid. In terms of the synthesis of niacin, pretty simple. If you start from 3-picoline seen here, we just need potassium permanganate to oxidize this methyl to the carboxylic acid, and therefore we have successfully converted 3-picoline to niacin. Very simple synthesis. All right, so we have a question. What are the main classes of LLDs? All right, so take a second, just see if you can remember it before you try to go back. All right, so if you answered bile acid binding resins, fibrates, statins, and niacin, then you would be correct. So now we're going to move on to our fibrates, which we have two examples here in terms of their names, Fibrates and clofibrate. So we have a image here of Fibrates. So we can see here that we have an aromatic portion, we have an ether portion, and we have a carboxylic acid seen here. So as a result of these fibrates, you have stimulation of lipoprotein lipase. Remember that enzyme that we mentioned earlier. Triglycerols are broken, VLDL and chylomicrons reduced, cholesterol in bile increase. So that is what happens when you intake your fibrates. In terms of your bile acid binding resins, they are generally water insoluble. They bind with bile acid and bile salt. So this is basically how they act. So they will bind with bile acid and bile salt, and they form a complex which is not absorbed. The enterohepatic recirculation is reduced, and here we have an image of this circulation, and this circulation is reduced as a result of these bile acid binding resins. Cholesterol use is increased, LDL levels fall, cholesterol level also falls. So cholestyramine resin, they absorbs and combines with bile acids in the intestine to form an insoluble complex which is excreted in the feces. This results in a partial removal of bile acids from the enterohepatic circulation by preventing their absorption. So as we can see, this is how it normally works. The absorption is prevented by cholestyramine, which is an bile acid binding resin. So as you probably would know, bile contains bile acid, which are critical for digestion and absorption of fats and other molecules. All right, so I mentioned cholestyramine, and it's basically a polymer. So as we can see, there's a small n right here, which means that this unit repeats itself, right? So that's one example of a bile acid binding resin, and there is cholestyramine, and the structure is seen here. Clearly, they are not related in terms of structure, but they fall in the same category. All right, so then we have our HMG-CoA reductase inhibitors. So we have, for examples, of your statins seen here, and I have the image here of lovastatin and simvastatin, and literally if you compare their structures, the only difference is that instead one has one methyl alpha to this ester group, while the other has two methyls in the same position. So this is basically, biosynthesis of cholesterol. It starts off with acyl coenzyme A, and then it's converted to HMG CoA, and then in the presence of HMG CoA reductase, which is clearly, once you see ACE, that's some enzyme, is converted to mevalonic acid seen here, and then via a series of steps, cholesterol is biosynthesized. So these statins are HMG CoA reductase inhibitors. So that means they inhibit the enzyme which facilitates the conversion of HMG CoA to mevalonic acid, and therefore obviously they would interrupt the synthesis of cholesterol, the biosynthesis of cholesterol. So HMG coenzyme A reductase, the rate limiting step for cholesterol synthesis. So in other words, if this is the slowest step and you interfere with this step, then therefore you interfere with cholesterol synthesis. As a result of these inhibitors, you have breakdown of LDL, oral absorption is good, first pass metabolism good, site of action is liver, excretion is mainly bile or stool. So we have another question. How is cholesterol biosynthesized, and how does LDLs interfere? All right, so we just spoke about it a while ago, right? So this is how, the biosynthesis of cholesterol, a number of steps. So some steps are missing. In fact, for your HMG CoA reductase, it is inhibited by our HMG CoA reductase inhibitors, and as a result of that, reducing or stopping the cholesterol biosynthesis. All right, so another type of LDL, probucol, it increases the rate of LDL metabolism. It blocks the intestinal transport of cholesterol. The net result is a significant reduction in plasma cholesterol levels, right? And so this is another LLD, I should say, lipid-lowering drug. And this is basically how it works. So I just spoke about it. All I need for you to do for the next class is to describe the action of the LLD probucol, and if you can find external information, that would even be greater. So you have reached the end of this lecture. Thank you for watching, and see you next time.